Transforaminal endoscopic discectomy is a procedure where we remove herniated disc material to decompress neural elements to relieve leg pain. Typically, it's done with a tubular retractor that's inserted through the natural opening in the side of the spine called the foramen. That allows us to enter the spinal canal and remove disc material off of the nerves, pretty much anywhere from about the second thoracic level down to L4. That procedure is performed with the patient awake under monitored anesthesia care. So the indications for transforaminal endoscopic discectomy are any disc herniation from T2 to the sacrum that can be accessed through the foramen as long as the patient is eligible for outpatient surgery. So the risks of endoscopic spine surgery are very similar to the risks of open spine surgery, and they include terrible things like death, paralysis, infection, bleeding, pain, need for future surgery, risks of anesthesia, risks of spinal fluid leak. The good part is that those risks are minimized with the endoscopic approach because there's less collateral damage to the soft tissues, so those risks are smaller. So there are some small additional risks to transforaminal endoscopic surgery, since the foramen and the exiting nerve root can sometimes be narrowed in patients with spine pathology. Inserting the tubular retractor can sometimes put pressure on the nerve and cause some numbness and pain for a short period of time after surgery. It typically doesn't happen immediately afterwards. It can happen anywhere from 2 days to 2 weeks afterwards. So the benefits of transforaminal endoscopic discectomy include removal of the offending pathology. Typically what we want to see is resolution of leg pain in the immediate post-op period. We notice that patients have more improvement in their back pain than they do from traditional surgery because there's less collateral damage and we don't violate the joint. The other advantage of transforaminal endoscopic discectomy is since it's done with the patient awake under conscious sedation, there's fewer risks of anesthesia. So the limitations after transforaminal endoscopic discectomy are actually quite minimal. We typically ask that you wait till you can walk on your tiptoes and you're not taking any narcotic medication to drive. Since we typically don't have to prescribe narcotic medication, most people are driving 2 days after surgery. In terms of bending, lifting, and twisting, we like to limit that to 10 pounds the first 2 weeks, and then when people can achieve level 4 in our core strengthening program, we let them go back to regular activities. The more of these that we do, we find that people tend to let themselves progress on their own, and it doesn't seem to have any deleterious effects. So with any discectomy, no matter how it's done, there is a risk of recurrent herniation. That is somewhere between 5 to 10%, no matter how it's done. The advantage of an endoscopic discectomy is if you do have a recurrence, it can typically be accessed through the endoscope a second time with, again, less morbidity than having the open surgery done the first time. So the wound after a transforaminal endoscopic discectomy is closed with a subcutaneous suture and sealed with a dab of glue. There's no band-aids or stitches or dressings to worry about. So you can shower the day of surgery and you're typically walking in less than an hour after surgery. In terms of limitations, we try to limit people to lifting no more than a gallon of milk the first 2 weeks, but we've been sort of unsuccessful with that because people typically will go back to doing more regular activities sooner. One of the interesting aspects of transforaminal endoscopic surgery is since the patient is awake during the surgery, we can actually converse and talk with them and ask them if their leg pain's better, which helps us guide in removing the offending pathology.